Hi everyone, and welcome to our module on cardiac action potentials. So this is a drawing of the action potential in a cardiac atrial or ventricular myocyte. And what this shows is the change in voltage across the membrane of the cell over time. So this is time down here on the x-axis. And it's showing that the voltage starts off at minus 85 millivolts, comes up to be positive, and then comes back down to minus 85 millivolts. Now let's talk about each phase of this process and how it occurs. So for simplicity's sake, I'm going to draw a nice oval ventricular myocyte here. And at rest, it has a voltage across its membrane of minus 85 millivolts. What does that mean? It means there are more negatively charged ions inside the cell and more positively charged ions outside the cell. And there are membrane pumps that make sure to keep this balance appropriate so that it's negative 85 millivolts all the time with more negative charge inside than outside. However, each myocyte is connected to its neighbor, so this might be a neighbor here, and it's connected by what's called gap junctions. And so these can allow ions to flow from one cell to the next. So when its neighbor depolarizes, it sends positive ions into this cell. That begins to push this negatively charged membrane potential upwards back towards zero. Because remember, it's negatively charged, so when you add positive charges, you start to cancel out the negative charge and drive it closer to zero. As it begins to move up, that triggers sodium channels in the membrane to open. So the sodium channels open in this phase 0 right here, and sodium rushes into the cell. Since sodium is a positively charged ion, it raises the membrane potential from negative back up to positive, and it goes all the way up to here, just a little bit above 0. Once it completes this phase 0 and reaches here, all the sodium that's going to move in has done its job, and now voltage sensitive potassium channels open and potassium begins to leak out of the membrane. So since potassium is positively charged, when it leaves the cell, it lowers the gradient across the cell, making it more negative. It starts to lower it, but then it stops and it sort of flattens out. We call this the plateau phase or phase 2. What happens here is that voltage-sensitive calcium channels open. They allow calcium to come into the cell while potassium is going out, and these two balance each other out, and as a result you get a flat portion in the action potential where the voltage isn't going up or down. Eventually the calcium channels do all they can and the potassium channels take over. They keep sending potassium out of the cell, thereby lowering the membrane potential all the way back to minus 85 millivolts, and we call that phase 4 at the end of the action potential. So why is this whole process so important? Well, as the voltage goes from minus 85 up to positive and back down, that whole process triggers sarcomere proteins to contract. This means that the atrial cells contract and the ventricular cells contract, and that's what pumps blood to the body. So blood would not pump to the body if atrial and ventricular myocytes did not go through this process of depolarization and repolarization. And it's very important you understand the ions involved in each phase. So phase 0 occurs because sodium rushes into the cell. Sodium is positively charged, so it increases the voltage across the membrane. Phase 1 occurs because potassium leaks out of the cell. Potassium is positive, so when it leaves the cell, that makes the voltage more negative. Phase 2 is a plateau phase where calcium and potassium are balancing each other. And then phase 3 is a negative phase where potassium is leaving the cell, driving down the voltage back down to phase 4. Now let's talk about the pacemaker action potential. So the action potential I showed you on the previous slide was for a myocyte in the atria or the ventricle. The cells in the SA node, the AV node, the His bundle, and even the bundle branches and the Purkinje fibers all follow a different process for depolarization and repolarization. Those cells don't sit at minus 85, they sit at a little bit higher voltage, around minus 60 or so. And as a result, all those sodium channels are closed, so they can't have the rapid upstroke we saw in the ventricular myocyte because the sodium channels aren't activated. However, these cells have something called a funny current, or IF, and it's named funny because when it was discovered it was thought to be unusual, and so therefore it was named IF, or the funny current. So when they are at rest, a little bit of sodium is creeping into the cell all the time. This means that the voltage is slowly climbing over time, as opposed to the myocyte action potential where it was flat at rest. These are not flat at rest. The voltage is always slowly climbing. And when they reach about minus 40 millivolts, some calcium voltage-dependent channels open and they allow it to depolarize very quickly. And then potassium channels open and they pump out potassium and the voltage comes back down. So as opposed to the very different shape of the myocyte action potential, these pacemaker action potentials look like what I've shown on this slide here. And the key is this phase 4 right here. Phase 4, you may remember, was flat in the myocyte action potential. Phase 4 here is always climbing up, and once it reaches minus 40, it shoots up and then comes back down and goes through the process again. So the slope of phase 4 is going to determine how quickly these cells fire. For example, if phase 4 was very slow like this, it would take a long time to reach minus 40 millivolts and fire. On the other hand, if phase 4 is rapid, it will reach it very quickly and fire. So the sympathetic nervous system is going to make this phase 4 go faster so that the SA node will depolarize faster. On the other hand, the parasympathetic system will slow phase 4 so that it will depolarize less quickly. So I told you that the SA node is a pacemaker, but so is the AV node, and so is the bundle of His, and so are actually the bundle branches and the Purkinje fibers. However, the SA node is the dominant pacemaker, and what do we mean by that? Well, we mean that it has the fastest phase 4. So it reaches negative 40 millivolts fastest and then depolarizes. It sends its charge down the line, and so the AV node may have a little slow upstroke like this. It's trying to reach minus 40, but before it gets there, the SA node tells it to depolarize. Thus, the AV node is not controlling the heart rate, the SA node is. However, if something goes wrong with the SA node, then the AV node can pace itself. So this is an EKG strip of a patient in heart block. So this is complete heart block. And there are P waves here being sent by the SA node, but they can't conduct. They can't get through the AV node to get to the ventricle. So as a result, we're having depolarization initiated by the AV node or the bundle of His, sending these narrow complexes out at a very slow rate. This heart is being paced in terms of QRS complexes from a lower site than the SA node, but that's okay because those cells have the ability to pace. However, you can see that they pace at a very slow heart rate. This is a bradycardic rhythm. If the SA node could pace, it would be pacing at a faster heart rate. So it's important to remember that the SA node is the dominant pacemaker because it has the fastest slope of phase 4, but that the other pacemakers can pace if something goes wrong with the SA node, but they just have a slower phase 4 slope. Okay, let's finish this module by talking about mechanisms by which arrhythmias occur. So when we talk about atrial fibrillation or AVNRT or ventricular tachycardia, those are arrhythmias. And it turns out there are basically 3 underlying mechanisms by which they all get initiated. And those are abnormal automaticity, triggered activity, and re-entry. Let's talk about abnormal automaticity first. This occurs when cells outside the conduction system acquire automaticity, meaning they acquire the ability to depolarize on their own. This often happens when there's some form of injury that causes membranes to leak ions, although it can occur in other circumstances as well. And it creates ectopic beats when myocytes depolarize on their own outside of the control of the normal conduction system and the SA node. So in terms of clinical examples, abnormal automaticity is the mechanism of formation of many premature contractions. When patients have PACs or PVCs, this means that ventricular or atrial myocytes have acquired the ability to depolarize on their own outside of the control of the SA node. Abnormal automaticity is also the mechanism of many forms of atrial tachycardia. It's also the mechanism of some forms of ventricular tachycardia. Another mechanism of arrhythmia generation is called triggered activity. This occurs when abnormal conditions cause a phenomenon known as after depolarizations. If we look at the action potential at the bottom of the screen, phase 0 is the normal depolarization of the myocyte. An after depolarization is a second depolarization that occurs at some point in phase 3 or phase 4. So for example, if the myocyte was in phase 3 and the membrane voltage was falling and then it depolarized a second time, that would be an after depolarization. And these can become self-perpetuating and they can lead to arrhythmias. After depolarizations can be classified as either early or late. An early after depolarization is one that occurs in phase 3, like I've drawn here. A late after depolarization is a second depolarization that occurs sometime in phase 4. Some clinical examples of triggered activity leading to arrhythmias include many digoxin toxicity rhythms. These are often triggered. In addition, the mechanism of torsade de Pointes, which occurs in the setting of long QT interval, is believed to be triggered activity and after depolarizations, and also some forms of ventricular tachycardia. Our final mechanism of arrhythmia generation is called reentry. In order for reentry to occur, there must be a mosaic of conducting cells present in the heart, meaning there must be conducting cells that have different electrical properties. In order to understand this, let's look at the diagram I've made on the screen, and let's imagine that an electrical impulse is traveling through the heart and then encounters 2 pathways with different conducting properties. One I've labeled A, one I've labeled B. In order for reentry to occur, there must be unidirectional block in pathway B. This means that pathway B must be unable to conduct in the forward direction, and therefore the impulse is blocked. Pathway A must conduct normally. That's why there has to be a mosaic of conducting cells. So pathway A will conduct the impulse, but then it can loop back around and go upward in a retrograde fashion through pathway B. If the conduction through pathway B is slow, by the time the electrical impulse makes it through pathway B, pathway A will be ready to depolarize again. This can create a circuit where electricity goes around and round and generates an arrhythmia. So now you can understand that in order for this to occur, there must be a mosaic of conducting cells, meaning cells with different electrical properties. You must have unidirectional block, as I described in pathway B, and there must be slow retrograde conduction, as I also described for pathway B. Some clinical examples of arrhythmias that can be caused by reentry include ventricular tachycardia, especially in patients who have scar in their myocardium. Imagine that a patient has had a heart attack and a portion of their left ventricle has been replaced by scar tissue. That scar tissue does not conduct electricity. Nearby, there may be some normal myocytes which conduct electricity normally. Between these two areas, that mosaic of conducting cells can develop, and that can lead to reentry, which will lead to ventricular tachycardia. AV nodal reentry tachycardia occurs when there are dual pathways in the AV node. That can lead to reentry, and I talk about this in a separate module. And then finally, AVRT is a reentry type arrhythmia that occurs in patients who have a bypass tract as part of the Wolff-Parkinson-White syndrome. And that concludes our module on action potentials.